everybody. Let's move on to part 2 of our general surgery review questions. So question 11 gives us a 45-year-old woman presenting to the ED complaining of sudden abdominal pain, which started 2 hours ago. She says she feels nauseous but denies vomiting. Physical exam reveals right upper quadrant tenderness and Murphy sign. Bowel sounds are normal. CBC and BMP are drawn and are unremarkable. There are no other vital or physical abnormalities. Right upper quadrant ultrasound is performed and reveals a gallbladder with a wall thickness of 2.8 millimeters. No stones are visible. Which of the following is the best next step in management? A. HIDA scan. B. CT of the liver. C. Elective cholecystectomy. D. Urgent cholecystectomy. Or E. Endoscopic retrograde cholangiopancreatography. And just a warning, I have horrible summer allergies, so I'm sniffling and sneezing all over the place. So hopefully I don't do that too much here, but if I do, you know why. All right, so the answer to this question is A, a HIDA scan. So what do we have here? We have a woman who has got, well, first of all, she's a woman in her 40s, and those are 2 of the fat female fertile in 40s, well, actually probably 3 of the fat female fertile in 40s, stereotype of typical woman that comes in with cholecystitis. However, even though she's got all the symptoms and physical appearance of cholecystitis, what she doesn't have are the objective signs of cholecystitis, which would be a fever, an elevated white count, and most importantly, an ultrasound that shows cholecystitis. And some of this is presupposed on the fact that you know what an ultrasound looks like with cholecystitis. Now, you can answer this question even without knowing that, because typically the patient with cholecystitis will have stones and will have a fever and an elevated white count. However, it's good to know, especially if you're an emergency medicine resident or an internal medicine resident, if you're one of the people who are taking step 3, but good to know, even if you're a medical student taking step 2, just to really impress them, to know what a normal right upper quadrant ultrasound looks like. And a normal right upper quadrant ultrasound will give you a normal gallbladder wall thickness. What is the normal thickness of the gallbladder? Less than 4 millimeters. So in this case, normal. No stones are visible, so we would expect to see stones with cholecystitis, either in the gallbladder, in the neck, or in the cystic duct. We don't see that here. And so, and then another thing you might see is sludge, which is just dehydrated bile, and a fluid around the gallbladder, pericholecystic fluid. So we see none of that here. With no fever, no elevated white count, no findings on ultrasound. So what we then diagnose the patient with is not acute cholecystitis, but possibly a motility issue with the gallbladder. And we can't diagnose that yet. We have to watch the gallbladder work. And we can't do that with an ultrasound, unfortunately. We have to use a nuclear medicine test, and that nuclear medicine test is called a HIDA scan. So a HIDA scan can tell us whether or not we have a patient with abnormal gallbladder motility. And this is also referred to as biliary dyskinesia. So if you get the HIDA scan and it's abnormal, you don't need to know what a normal HIDA scan looks like or how it's described. But if a HIDA scan is described as abnormal, then you have a patient with biliary dyskinesia. And the treatment for that is an elective laparoscopic cholecystectomy. By no means you have to remove the gallbladder. The gallbladder really isn't diseased. It doesn't pose any direct threat to the patient, but it's a pain, literally. So a lot of patients will elect to have it removed, and we're happy to oblige them. If it's a normal HIDA scan, though, you should consider other diagnoses. So how are we working up this patient? Let's start over at the very beginning. So we have the patient coming in with right upper quadrant pain, doesn't have jaundice, which is a good sign. It means there's nothing going on in the ducts. It's probably in the gallbladder. So right upper quadrant pain without jaundice, we work up the labs. Most importantly, got to get the CBC and the CMP, and then amylase and some of these other tests. But importantly, CBC and CMP, because that's going to help us determine if there's anything wrong as far as elevated white count, if there's any kind of dehydration, etc. So those tests need to be ordered. Amylase is ordered because the pancreas is kind of in the same area, and if a patient has vague pancreatitis, it can be rather described as upper abdominal pain. It can be described as right upper quadrant pain. So an amylase is good to have just to rule that out, because when you have right upper quadrant abdominal pain, yes, pancreatitis is on your differential. Beta HCG and urinalysis. Now, of course, beta HCG you're only going to get in women. Urinalysis you can get in women or men, but it's more pertinent for women. So why urinalysis is more important in women? Because women get UTIs more than men do, and UTIs can present with right upper quadrant pain. Normally it's described as flank pain, but it can be right upper quadrant pain. I mean, different patients describe things differently, and you got to know that. The beta HCG, why do we get that? Well, we get that in any woman of reproductive age, which is defined very broadly, so almost shockingly broadly, so 12 to 60. So beta HCG will tell us two things, and two things that are important. One, the woman may be pregnant and not know it, and that can be the cause of the pain if she has an ectopic pregnancy. But it can also be important, and is important, if she has a diagnosis of acute cholecystitis or choledocholithiasis, where we're going to need to administer IV antibiotics, because there are some antibiotics that are teratogenic, and we cannot give those to women who are pregnant. And in the litigious culture of the United States, where we love to sue doctors, if you administer antibiotics to a woman, even though she doesn't know she's pregnant, doesn't tell you she's pregnant, it's incumbent upon you to know that the woman is pregnant. So we get the beta HCG, and if it comes back 0, well, then she's not pregnant. And so we can go ahead as usual. But if she is pregnant, well, first off, we have to inform her of that. And secondly, it's going to change our choice in IV antibiotics so that we're not giving anything teratogenic. So with the right upper quadrant ultrasound, it can come back unremarkable, as it did in this patient. We do the HIDA scan, etc. If it comes back remarkable, meaning with findings consistent with cholecystitis or choledocholithiasis, well, let's start off with cholecystitis. So with cholecystitis, you have stones in the in the gallbladder, in the cystic duct, or in the neck of the gallbladder. You'll also have, most importantly, wall thickening. Remember, the normal thickness of the gallbladder wall is 4 millimeters or less. If it's more than that, you have thickening of the gallbladder wall, and that needs to be noted. Also, pericholecystic fluid, because of the backup, the increased pressure, you get basically a transidate of fluid escaping the gallbladder and into the area around the gallbladder. So these findings are consistent with a blockage in the gallbladder, an infection in the gallbladder, and this is the diagnosis of acute cholecystitis. What do we do? Operate? No, we do not operate right away. We want to preferably not operate at any point within the next 48 hours because, and this goes for pretty much anything in surgery, we do not want to operate on an organ that is inflamed, actively inflamed. Why? Because there are more complications if you operate on an organ that's inflamed, especially infected inflamed, than if you operate on an organ that's calmed down, so to speak. A lot of surgeons will call it cooled down, a cooled down organ that's no longer inflamed. So what do we do with these patients? We diagnose them with cholecystitis. We're going to admit them. We're going to put them on NPO, so nothing to eat or drink. And the reason we do that is because anything that you put into your GI tract is going to stimulate your gallbladder to a certain extent. And we don't want that to happen because we have an infection in the gallbladder. So we put them on NPO. Anytime you put a patient on NPO, you usually are going to have to put them on IV fluids because you don't want to dehydrate them. In addition, you'll probably start dextrose too because you want to keep their sugar levels normal. And then NG suction can be done, but it's not necessary. And that would be like, let's say the patient just had a big meal and you want to get some of the food out so that you don't worsen what's going on. You can take what's in the stomach out. And then finally, but very importantly, IV antibiotics. And remember, what are we trying to do here? We're trying to let their cholecystitis resolve on its own. By on its own, we mean with some antibiotics. to prevent complications. So we give them IV antibiotics, broad spectrum, and after 48 hours, we observe them, admit them, 48 hours, if their symptoms have resolved, they can get a cholecystectomy on an elective basis within the next 6 months. That having been said, it's preferable to have the patient get their gallbladder taken out during the same visit, because what happens if you send them home? They, in their stressful lives, forget about the fact that they need to get their gallbladder taken out, or they procrastinate it, and then they wind up not coming into the hospital again until their gallbladder is inflamed again. And cholecystitis is not by any means a benign condition. You can get sepsis, and theoretically you can die from it. So it's important that these patients have their gallbladder taken out. So usually we take it out during the same visit, but it is technically elective. If the symptoms, however, persist or worsen during these 48 hours, then you're going to operate. Even though it's an inflamed organ, then we still we'll have to operate. Even though we don't want to, we have to, because the patient's symptoms are worsening, and you got to get this out. If you have a stone in the common bile duct, this would be unusual, but it is possible to have a stone in the common bile duct with this presentation. Typically, when you have a stone in the common bile duct, you'll have jaundice because you're getting blockage of your biliary tract. But it's possible to have a stone in the common bile duct. If it is a stone in the common bile duct, the diagnosis is choledocholithiasis in addition to the cholecystitis that's happening. And so we treat this the same way in general. But another important part of if a patient has choledocholithiasis is that we do an ERCP on the patient, and that's to visualize the biliary tract. So this patient did not have a stone in the common bile duct, obviously, so we don't need to do an ERCP. In addition, with choledocholithiasis, though, we treat them the same way as acute cholecystitis, with the admission, the IV fluids, the NPO, the IV antibiotics, and we observe them. All right, question 12. A 23-year-old recent medical school graduate presents to the ED complaining of severe right lower quadrant abdominal pain of sudden onset. He denies any other GI symptoms. Vitals are a blood pressure of 130/90, heart rate of 110, respirations 20, temperature of 100.6. psoas and obturator signs are both positive. Tenderness is confined to the right lower quadrant with no rebound or guarding. Physical examination is otherwise normal. Which of the following is the best next step in management? A, observation, B, rectal suppositories, C, elective appendectomy, D, abdominal x-ray, or E, abdominal CT. All right, so the answer to this one is D, abdominal x-ray. So if you answered abdominal CT, you were on the right track, but here's the thing with appendicitis. When it's in a very typical, very likely presentation based on the history and the physical and the labs, that they've got this sudden right lower quadrant pain, not a chronic right lower quadrant pain, sudden right lower quadrant pain. They've got a physical that shows a positive psoas and obturator sign, pain at McBurney's point. They've got a fever, they've got an elevated white count, they've got a positive psoas and obturator sign. If they got all these typical they got this very typical presentation, both subjectively and objectively, of acute appendicitis, the best initial diagnostic step is an abdominal x-ray. Now I know, because I've seen it, and I think we've all seen it, that doctors in the ER, who are the typical doctors who have to deal with acute appendicitis, just go straight to a CT. And there is reason behind that. Abdominal x-ray, only about 10% are diagnostic. But that's not best practice. It's really lazy practice. And I don't like lazy practice, and neither does the USMLE. So if the patient has a very likely, very clear clinical picture of acute appendicitis, you're going to get an abdominal x-ray first, even though you know in the back of your mind you are probably going to have to still get a CT to diagnose them. Now, if the diagnosis of acute appendicitis is questionable, then you can go straight to CT. But if it's this patient was very obvious appendicitis. All right, so symptoms are going to be recent onset of right lower quadrant pain. It is possible to have a missed appendicitis, in which case you'd have right lower quadrant pain for maybe a couple days. I talk about that in the appendicitis section, so if you want to know more about that, you can look there. Nausea and vomiting, mostly due to the pain, which is very severe, and anorexia, just associated with nausea. If you're nauseous, you usually don't want to eat, and then fever because of the inflammation. Physical exam, you'll get pain on palpation of the right lower quadrant. Very typical point is because it's right where your appendix sits. Guarding and rebound tenderness is possible, but not always the case. And then psoas and obturator sign. So the natural history of appendicitis, of acute appendicitis, is good to know. So by natural history, of course, we mean how does it progress if we're not treating it. So when a patient gets acute appendicitis, the triggering pathology behind it is usually a fecal lith. And a fecal lith blocks the lumen of the appendix. Remember, back to gross anatomy, that the appendix is continuous with the cecum. It's just a little tail off of the cecum, the very first part of the large intestine. And so if you block the appendix with something, then you're going to get an increased pressure because what's in the appendix can't get out. That pressure is going to cause the initial pain. In addition to the pressure, you'll get edema and ultimately an infection. That infection and the edema is going to cause necrosis. And the necrosis will lead to an infection on the outer part of the appendiceal wall, the appendiceal lumen wall area. And that necrosis, that infection, will irritate the peritoneum. And that's what causes your guarding and rebound tenderness at the right lower quadrant. So if you have a patient very early on in acute appendicitis, you may not have that. But if they start to have the necrosis, then by then you'll have the guarding and rebound tenderness. Now, after that, if the patient doesn't go diagnosed, a lot of times what will happen, if they don't form an abscess, their appendix will burst. And when the appendix bursts, the pain goes away because now you no longer have all that pressure, but it's going to be bad ultimately because what burst? The appendix, and it was full of bacteria. And that bacteria is going to seed the peritoneum, and it's going to cause generalized peritonitis. So then you'll have pain everywhere in your abdomen, and it'll be that guarding and rebound tenderness that is typical of peritonitis. The psoas and obturator sign, these are muscles that sit right up next to the appendix, and so if you have those positive, it's generally because you have an inflamed appendix that is causing pain up against these muscles that are being contracted. So that's why those are positive. And these are relatively specific signs for acute appendicitis. All right, so back to imaging. This is very misunderstood. So, like I said, if you have the typical presentation of appendicitis, the USMLE is going to expect you to go first to abdominal x-ray. And there's a reason for that. A lot of patients, including this patient, who have presented with acute appendicitis are young. And we don't want to expose anyone to unnecessary radiation, much less young patients who can go on to develop cancers from that. Patients who are young are at much greater risk. They're much more sensitive to the radiation than older patients. So we get the x-ray first. X-ray, it's very, very, very small amount of radiation relative to the CT scan. So we get the x-ray, and in about 10 to 15% of patients with acute appendicitis, you will be able to see the fecal lith that's blocking the appendix. So what do we do when we're looking at it? Well, it's not that difficult to find problems with the appendix when you're looking at an x-ray because you just go straight to where the appendix is. You know where it's at. It's in the right lower quadrant, and it's usually right up around, in most patients, it's right up around the ileum. So here it is right here. Appendix is down here. But I liked this picture because this is like one of the biggest fecal liths I've ever seen in my life. And this is how the USMLE will give it to you if they want to show you a fecal lith, because they just want you to know that a fecal lith is associated with appendicitis. But in real life, you'll probably never see a fecal lith this big. But if you look close enough, you should be able to find it. Now, let's say that if this came back positive, then yes, you send them off for surgery, treat them as usual. But let's say that this came back and you didn't see a fecal lith. then you go ahead and take them for a CT. Diagnosing appendicitis on CT is a little different because we're not looking for the fecalith so much as we're looking for features of the appendix. So when you're looking at a CT on a patient, you're looking for inflammation of the appendix. By inflammation, I primarily mean edema. And you're also looking for filling with contrast. So remember, this was a CT with contrast. So contrast, of course, is this white stuff in the large intestine here and small intestine. But remember what I said about the appendix. It's continuous with the cecum. You should be able to get your contrast, in a normal person, you should be able to get your contrast into the appendix because there's an opening between the cecum and the appendix. In a patient with acute appendicitis, that opening is not really there because it's blocked. So what you'll see is an appendix that doesn't fill with contrast. That is appendicitis. Okay, but then also you'll see this inflammation, edema around the appendix, and in some cases you may even see an abscess. Here's the psoas muscle right here, and this is why the psoas sign is positive. Appendectomy. So this is the surgery we do. Today it's almost always performed laparoscopically. I had an appendectomy done about 5 years ago, and the one thing I noticed, which was really nice to know for clinical practice, you never forget it when it happens to you, is the incredible shoulder pain after the laparoscopic procedure. Remember that your diaphragm can be irritated very easily, and when the diaphragm is irritated, the pain refers to the shoulder. And so if you talk to patients, in retrospect, when I was on my surgery rotation as a medical student, I heard this all the time, but I didn't really pay attention to it because it sounded irrelevant. But thinking back to it, and for the most part it is, because it's nothing you have to do anything about, it's not harmful, it's just a transient issue. But if you have patients that tell you, oh, my shoulder hurts, the reason is because of the diaphragmatic irritation, because you're pumping the diaphragm, you're pumping the abdomen full of gas. And so that's going to invariably irritate the diaphragm. So that's something you can tell your patients. It's not anything to worry about. It will go away within a week, usually. All right, so today it's almost always performed laparoscopically. And this is a great thing because the laparoscopic wounds, there's 3 of them, one usually on the left side, one on the lower right side, and then another one like usually around the belly button where you pump up with gas. The wounds are very, very, very small, like 1 centimeter. And the smaller the wound, the less likely it is to get infected. And that is a very, very nice thing because infection is pretty much the most common general surgical complication. And with infection, you get abscess and all these terrible things that you don't want to have to deal with. So laparoscopic approaches are preferred in general if you can do them. Now, when you're doing the laparoscopic procedure, or any procedure really, where you're looking for the appendix, if you find the appendix, you've already diagnosed appendicitis, but you find the appendix and it doesn't look inflamed grossly, you're still going to take it out because the appendix can be inflamed but not look inflamed from the outside. It can still be inflamed on the inside, so you're still going to want to take it out. But this is very important you know this. And if you are a medical student and you're on your surgery rotation right now, you can really impress your attending surgeon if you know this and they ask you this. If you see an appendix that's not inflamed, yes, you take it out, but what do you look for after that? You look for a Meckel's diverticulum. A Meckel's diverticulum, remember that outpouching in the end of the small intestine, about 2 feet from the cecum, that can carry that ectopic tissue. The Meckel's diverticulum may not present with symptoms until it gets inflamed with bacteria. And so if you find a normal-looking appendix, you're going to look for a Meckel's diverticulum because Meckel's diverticulitis, an inflammation of the Meckel's diverticulum, presents exactly like appendicitis most of the time. So you'll really impress your attendings if you know that you've got to look for that Meckel's diverticulum. Because if you left that there, you're not treating the patient. You took out a normal appendix and you left what's causing the problem in the patient. So if you have a normal-looking appendix, look for the Meckel's diverticulum. It's very easy to find it. Remember, 2 feet from the rule of 2. It's 2 feet from the cecum. 2% of patients, 2 centimeters, etc. Okay, complications from appendectomy, and this goes for laparoscopic and an open procedure, is adhesions. That's primarily because you're inflating the abdomen, and so you can get an exaggerated scar response from that. If you see patients, if they had their appendix taken out more than 15, 20 years ago, it was probably the open approach. If they've had it taken out within the last 10 years, especially in the last 5 years, it was almost certainly performed laparoscopically. All right, question 13. A 57-year-old man presents to the ED complaining of abdominal pain and constipation. He says he hasn't had a bowel movement for the last 2 days, and he has been having crampy pain on and off since this morning. He denies vomiting, but says he feels somewhat nauseous. He describes himself as otherwise in good health. His surgical history includes open appendectomy at age 30, open Roux-en-Y gastric bypass at age 38, and a laparoscopic cholecystectomy 3 years ago. Physical exam is significant for distension and discomfort on palpation. Bowel sounds are hypoactive. I apologize for my terrible typing here. Rectal exam is negative for masses, and there is no stool in the rectal vault. Abdominal X-ray shows multiple dilated loops of small bowel and air fluid levels. Which of the following is not going to be part of this patient's initial management, or would likely not be part of this patient's initial management? So if you're going to be taking step 3 soon, you need to know how to write out a list of things you need to do for the patient. But when you're getting tested on that, they're going to give you a list of everything you could possibly do for the patient, and you don't want to check off the things that aren't necessary. So what are you not going to do for this patient? What are you least likely to do for this patient compared to the other ones? The answer is, here is your multiple dilated loops of small bowel with air fluid levels. Okay, so here's the answer. Exploratory laparotomy. So it's easy to think this because this patient has a very, very, very typical history, symptoms, and physical and presentation of small bowel obstruction. But small bowel obstructions, most of the time, will resolve on their own. And we prefer to let them resolve on their own rather than going in and doing surgery. So what we're going to do is we're going to put them on NPO, give them IV fluids, maybe decompress their stomach if they have food in there. It's not totally necessary, but it is part of. It can be part of your plan. And then other things that you can do here on Dancitron IV. This is an antiemetic, so this patient is nauseous. So it would be a nice thing to do for this patient to offer him, as needed, an antiemetic, which of course has to be IV because he can't take anything orally. So. But the one thing we don't want to do right away, if we don't have to, is an exploratory laparotomy. Now, if the patient starts to develop really severe abdominal pain, a fever, an elevated white count, then we're concerned about necrosis of the bowel, of the small bowel. And in that case, we do an exploratory laparotomy, take out the small bowel that's diseased. But most of the time, small bowel obstructions will resolve themselves, and so we like to observe them. Now, if this were a patient who had came in, this was a patient actually that came into the ED. So if it's a patient that comes into the ED, of course, we have to admit them. You can't just send them home and say, oh, just don't eat anything and come back if you start to develop a fever. You can't do that. So you've got to make sure that these patients are admitted, right, even though you're not doing surgery. And you'll probably admit them to a surgical unit. Question 14. A 35-year-old woman presents with recent weight gain of 40 pounds in 6 months, along with stretch marks on her abdomen, which distress her greatly because she finds them to be unsightly. Dexamethasone suppression battery is performed, and cortisol levels are drawn, both with a low dose of dexamethasone and a high dose of dexamethasone. It is found that the patient has elevated levels of cortisol with the low dose of dexamethasone, but suppressed levels greater than 50% of the original level with the higher dose of dexamethasone. Based off of these results, which of the following treatments would most likely be needed to achieve a cure in this patient? A. Transsphenoidal resection. B. Adrenalectomy. C. Total hysterectomy. D. Spironolactone, or E. Meteripone? All right. And the answer here is A. Transsphenoidal resection. So I wanted to make this somewhat vague because patients in real life are usually somewhat vague. They're not your typical textbook presentation. But if you look at this patient's presentation, she has a weight gain of 40 pounds and in the last 6 months, which is severe, and these quote-unquote stretch marks. I didn't want to use the word striae because it makes it obvious what it is. But when you look at it, they look like the typical stretch marks that everybody else gets. A couple exceptions. They're a little bit bigger than typical stretch marks, and they're purplish. And this is consistent with hypercortisolism, with Cushing's syndrome. Why do you get those striae with Cushing's syndrome? 2 reasons. You're gaining weight quickly, and so your skin doesn't really have time to adapt to you gaining weight. And secondly, cortisol reduces the integrity of your connective tissue. And so the stretch marks look really, really, really bad for those 2 reasons. So whenever you have a patient with suspected Cushing's syndrome, not Cushing's disease, Cushing's syndrome, you get this dexamethasone suppression battery. So I talk about this at length both in the endocrinology section and when I talked about Cushing's syndrome. The USMLE is absolutely infatuated with the dexamethasone suppression battery and working this up and figuring out what the cause of the Cushing syndrome is. So if you know this like the back of your hand, you will serve yourself well to get 2 or 3 free points on the USMLE. So let's say that you've got a patient with suspected Cushing's. The very, 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 very first step to do is a low-dose dexamethasone suppression test. The reason we do the low-dose dexamethasone suppression test first is because it weeds out the patients who are normal, who just appear like they have Cushing's syndrome. So what you do is you give them 1 milligram of dexamethasone before they go to sleep, usually about 10 o'clock at night, and then you measure their cortisol level in the morning. In most patients, like you and me, dexamethasone will suppress cortisol because it acts as a negative feedback. So if your dexamethasone suppression test at a low dose comes back suppressed cortisol, low cortisol, or normal, then you know that you don't have Cushing's syndrome. Why do you know that? Because with Cushing's syndrome, regardless of the fact that you're giving this small dose of dexamethasone, you're still going to continue to secrete cortisol, regardless of what the reason is. So only if you have elevated cortisol would you go on with this test. If you have suppressed or normal cortisol, it's a normal patient, at least they're not hypercortisolism, and you should consider an alternative diagnosis. If the patient continues to have the elevated cortisol, however, despite the low dose of dexamethasone, you can approach this one of 2 ways. And I bring this up because you may see it performed in different ways. I don't think the USMLE, though, is going to expect you to choose between the 2 because it can be done in 2 ways. There is a small percent of patients that come back with false positives from the low-dose dexamethasone suppression test, meaning that they're not Cushing's syndrome, but they have an elevated cortisol despite being given the low dose of dexamethasone. So that is possible. And so what a lot of clinicians like to do before exposing the patient to the much higher dose of dexamethasone, which is like 8 times higher than the low dose, is to make sure that this was really hypercortisolism and not a false positive. But to do that, you take the 24-hour urine-free cortisol. And if the 24-hour urine-free cortisol is normal, then it was probably a false positive, and you should consider an alternative diagnosis. But if in most patients it's elevated, and most patients who have the positive low-dose dexamethasone suppression test, they do wind up having an elevated 24-hour urine-free cortisol that's higher, then it confirms your low-dose dexamethasone suppression test, and you're going to diagnose them with Cushing's syndrome. And that brings us to another point. What's Cushing's syndrome as opposed to Cushing's disease? Cushing's disease is in your pituitary. Cushing's syndrome is anything where you have high cortisol. Right? So I could take cortisol right now and inject it into my blood, and I have given myself Cushing's syndrome. But I didn't give myself Cushing's disease because Cushing's disease is a pituitary adenoma. So once we have gotten our low-dose dexamethasone suppression test and/or our 24-hour urine-free cortisol, which shows positive for hypercortisolism, the next step is a high-dose dexamethasone suppression test. The thought here and the reality is that if you give a patient a high dose of dexamethasone, 8 milligrams, if it is a problem in their pituitary, the high dose will reduce the cortisol. So you'll have a response to it. And so if by being given the high dose dexamethasone, your cortisol level drops off from what it was, then you can make the diagnosis or the presumptive diagnosis of Cushing's disease, which is a pituitary adenoma, in which case you would take the patient in for imaging of the brain. If there is no response to the high-dose dexamethasone, meaning they continue to have high cortisol despite the 8 milligrams of dexamethasone, then it's one of two things. They either have an ACTH-secreting tumor, which is a cancer that's just making ACTH, so this is just like a paraneoplastic syndrome, or they have an adrenal neoplasia, so a tumor on their adrenals. The way to differentiate these is quite easy. You just get an ACTH level, and as you would suspect, with an ACTH-secreting tumor, you have a high ACTH level. If you have an adrenal neoplasia that's just spitting out cortisol, the cortisol is going to negatively feed back to your pituitary, and so your ACTH-secreting, or your ACTH level will be not only normal, it'll be actually low. So with a low ACTH level, then the presumptive diagnosis is an adrenal neoplasia, in which case you will get an abdominal CT to find it. If it is a high ACTH level, that's bad news. That means that the patient probably has a lung cancer. There are other cancers that can do this too, though. But lung cancer is the first one we think of, so then we get a chest CT. All right, so this is the workup for Cushing's syndrome. Like I said, USMLE absolutely loves to test on this. You will get a few questions on this, I guarantee you. This is, okay, let's go back to our answers here. So why do we choose transsphenoidal resection? Well, that's how you remove a pituitary adenoma. We know that that's what this patient has, or at least that's the most likely diagnosis, because she had the low-dose dexamethasone and didn't respond to that, so she continued to have hypercortisolism. But with the high dose of dexamethasone, it suppressed her cortisol levels. And as you see here, if you get a reduction in your cortisol with the high-dose dexamethasone test, then it's more than likely the pituitary adenoma. So a transsphenoidal resection is what you do for that. An adrenalectomy would be done for an adrenal adenoma, which would be the case if this patient didn't respond to either the low-dose or the high-dose dexamethasone test. And then the rest of these are kind of outliers. So total hysterectomy. This is what we do as a last resort treatment for patients with polycystic ovarian syndrome. This patient doesn't have that. How do we know that? Well, she's got hypercortisolism, and that's not a part of polycystic ovarian syndrome, at least not responsive to the dexamethasone, the high-dose dexamethasone suppression test. So as far as polycystic ovarian syndrome, they do have some symptom similarities to Cushing's syndrome in as much as they get the weight gain. Because of the quick weight gain, they can get stretch marks. But in addition to that, you also have some androgen symptoms. So you get the hirsutism, the growth of hair on their upper chest, maybe on the pubic crest moving up from their vagina. They get facial hair, and there's some other things. You get voice deepening, symptoms consistent with higher testosterone androgen levels. So that's polycystic ovarian syndrome. That's not this patient, but it's definitely should be part of your differential when you're considering a weight gain and stretch marks and stuff like that. This is very common in women in the United States. So this is something that OBGYN will expect you to know. And most of the time you will refer them over to OBGYN for therapy for this. Spironolactone is an aldosterone inhibitor. This would be, this is not the problem in this patient. This patient has a hypercortisolism. So that's not going to be useful for this patient. And then metyrapone is not used for the treatment of pituitary adenomas. Okay, so hopefully that is relatively understandable and straightforward. And then this is the transsphenoidal resection. It looks like a medieval torture device, but it's not. So the nice thing about, I guess you can consider a nice thing about having a pituitary adenoma is that the pituitary sits right above the sphenoid sinus, which is roughly in the area, if you go back, if you want to approach it orally, you can go up above the hard palate. But if you approach it nasally, you go straight back and you go right through the sphenoid sinus and through the sella turcica, and boom, you're right at your pituitary gland. So you're doing neurosurgery, yes, but you don't have to go through hardly any brain matter other than your pituitary. All right, question 15. A 32-year-old male presents to your clinic complaining of fatigue, fever, and abdominal pain of 5 days' duration. He is generally in good health and works as a Catholic priest at the local parish. He returned 3 weeks ago from a missionary trip in Nicaragua, but says, and your records confirm, that he received all recommended vaccinations for travel to that region. He has no surgical history, and he denies sexual activity or drug use. On physical examination, he's febrile at 101.5 degrees, vitally stable and notable for mild scleral icterus and right upper quadrant tenderness. Right upper quadrant sonogram is performed and is significant for a singular 1.0 centimeter hypoechoic mass in the liver parenchyma on the right lobe. This finding is confirmed on CT. Routine labs are ordered and reveal elevated white count with left shift, elevated transaminases, and total bilirubin. Which of the following medications will most likely benefit this patient? A. Ribavirin, B. Imipinum, C. Metronidazole, D. Tigersilin clavulanate, or E. Ceftriaxone? Okay. Give you time to pause here, and answer is C. Metronidazole. So I wanted to ask this question for 2 reasons, and 2 very important reasons. 1 on the scientific side of medicine, 2 on the professional side of medicine. So let's talk about the professional side of medicine first. So in the United States, if you practice or have been educated outside the United States, you might not be aware of this because it's kind of a cultural thing. People are very shy about talking about sex around strangers. And that's probably a lot of people worldwide. But this goes to doctors and patients. And there have been studies that have shown that when a sexual history is not taken, the reason was because the physician was too shy to ask about sexual history, or felt that they may make their patient uncomfortable by asking them about their sexual history. Now, on the other end of things, patients are often unwilling to talk about their sexual history or bring it up. They're usually willing to talk about it. A lot of times they're unwilling to bring it up because they feel like they're going to make their doctor uncomfortable. So you have a lapse in communication on both sides. Doctor feels they're going to make their patient uncomfortable. Patient feels they're going to make their doctor uncomfortable. Whose job is it to bring up the sexual history and ask about it? It is your job to bring that up, not the patient's job. So you need to ask about sexual history. That having been said, there are certain people we may be even more shy to talk about sexual history around. Catholic priests, for instance. Well, they're supposed to remain celibate. I don't need to ask them about their history. I was trained at a Catholic hospital. I saw a lot of members of the clergy and the nunnery. It's kind of embarrassing to talk about that around it, but you still have to ask it. It is absolutely vital, especially when you are dealing with a patient such as this, who on their differential diagnosis may have something that could have been sexually transmitted. So you have to ask them about their sexual history, regardless of the fact that it may make you uncomfortable. And it's as simple as saying, are you sexually active? That's it. 4 words. You don't need to belabor it. You just ask. If they say no, you take them at their word. If they say yes, then you can ask more. But it is your job to open the line of communication. All right? And then, of course, also drug use. You know, it may be uncomfortable to ask an 80-year-old nun if she uses drugs, but you still have to do it. It's part of taking a full history. All right, so now let's move on to the science end of this. So we have a patient that has what is almost certainly a liver abscess. And that's made very obvious. He's got a history, elevated white count, elevated liver enzymes, but also this mass in his liver parenchyma. Also important, though, here is that he just returned from a missionary trip in Nicaragua. And in the developing world, by the developing world I mean mostly Central America, parts of South America, Africa, Southeast Asia. In the developing world, there are liver abscesses can be a little bit more common because they are exposed to this parasite that causes the amoebic abscess, Entamoeba histolytica. So liver abscess is the most common manifestation of Entamoeba histolytica. Remember, you can also get bloody diarrhea from it. But this is the most common presentation outside of the intestines of Entamoeba histolytica. So what we're concerned with, especially now, is an abscess of the liver. Liver abscesses in the United States, supposedly in Canada, Europe, etc., are very uncommon. They don't happen very often. But and when they do happen, most of the time, they're pyogenic. They're caused from bacteria. But in the developing world, it's common to run into Entamoeba histolytica because the water supply might not be as taken care of. So we're concerned with this patient because he just got back from Nicaragua. And so it may be that he has an amoebic abscess. That having been said, how do we rule out that it's amoebic and not pyogenic, or pyogenic and not amoebic? Plainly said, we can't. We generally just work on the history. So when a patient has a history of travel, recent travel to developing countries, we work on the working diagnosis that this is an amoebic abscess, because amoebic abscesses are more common in the developing world than pyogenic abscesses. On the other hand, if you took this sentence out, he returned 3 weeks ago from a missionary trip in Nicaragua, and replaced it with he has no recent history of travel outside the United States, now you've got a patient that you're working with a working diagnosis of pyogenic abscess, and that's going to be a different approach. So the question asked, which of the following medications will most likely benefit this patient? Well, you can take ribavirin out because that's for Hep C, and we're assuming that we're taking him at his word that he hasn't been sexually active. Of course, if you really need to down the road, if you can't figure out what this is, you can draw titers, but we're going to take them at their word for right now. But also you've got this mass in the liver, and that's clearly some kind of abscess. And so you're left with 4 choices. B, D, and E are good drugs to use in pyogenic abscesses, and that may be indeed what this patient has, but metronidazole is a drug that can be used both for amoebic abscesses and for pyogenic abscesses. Note that you can't use drug therapy alone for pyogenic abscesses, but for amoebic abscesses, you can. So let's talk about amoebic abscesses of the liver. We kind of already talked about it. It's quite uncommon in the U.S., even among liver abscesses. Of all the liver abscesses in the U.S., it's about only 10%. But worldwide, amoebic abscesses are more than pyogenic abscesses. And, so not only worldwide, but even patients in the United States who have had recent travel to endemic areas. And like I said, that's pretty much the developing world. So some patients have a history of diarrhea, particularly dysentery. That's because of the entamoeba causing destruction of the lumen of the intestine. But some of the other symptoms include fever, right upper quadrant pain, hepatomegaly, occasionally jaundice, which I can't remember. Do we have in this patient? Yes, we had mild scleral icterus. But in general, it's similar in presentation to a pyogenic abscess. Certainly, by symptoms and history alone, you can't rule out one or the other. You can make a working diagnosis, but you can't rule one out or the other. For diagnosis, the suspicion is gathered on sonography, which we did on this patient, and then the best initial diagnostic test after that is to get a CT. And that's true for both amoebic abscesses and pyogenic abscesses. Typically, when you're looking at the abscess on imaging, amoebic abscesses tend to be more singular and more confluent and more clean appearing. And that's a terrible word. It's not a radiology word, but when I show you the picture, you'll see what I mean by that. But your routine lab should also support your diagnosis as it did in this patient. That's also important. Okay, pyogenic abscesses, on the other hand, this is more common in the U.S. Like I said, if this were, if our patient in this vignette had not traveled outside of the United States in the recent past, we would be assuming that this was a pyogenic abscess. It presents the exact same for the most part as an amoebic abscess, but there's some very important differences as far as how we manage the pyogenic abscess. A pyogenic abscess absolutely, quintessentially, always needs to be drained, whereas an amoebic abscess doesn't. As a matter of fact, we prefer to not drain it if we don't have to. And so with amoebic abscesses, we prefer to start them on metronidazole, observe them, and see if their symptoms go away. With a pyogenic abscess, basically, if it was a person in the U.S. who has not been outside of the U.S., we would just diagnose them with a pyogenic abscess and we go straight towards drainage. We wouldn't even bother with observation. So the treatment for a pyogenic abscess, and for any abscess that does not respond, even if it happened to be an amoebic abscess that doesn't respond to metronidazole, you're going to drain it. And with a pyogenic abscess, you're going to see pus, but with an amoebic abscess, and this is important to know because USMLE loves to use this keyword, you're going to see a drainage that appears to look like anchovy paste. That sounds terrible, but that's what they say. All right, so if it's a pyogenic abscess, if you suspect pyogenic abscess based on the fact that the patient hasn't been outside of the U.S., you're going to go towards drainage. If it's an amoebic abscess, meaning the patient is, if you're working in the developing world or the patient has recently been to the developing world, you're going to admit them, put them on metronidazole, see if they respond. If they don't respond, then you can go ahead and drain it. Okay, so here's what I meant by clean looking. This is an amoebic abscess right here, and this is definitely bigger than the one we had in this patient. But here's an amoebic abscess, and what you can see here is it's relatively confluent, circular, ovoid in appearance, but it's clean looking. I don't know what better word to describe it as. When you compare it to the pyogenic abscess, where you have all this necrosis stuff going on, and you've got multiple sites of infection, kind of multilobulated, and it just looks a lot worse than this amoebic abscess, which looks kind of more like a cyst. But it's an abscess, but it looks like a cyst, kind of. Okay, I'm not a radiologist, so if you want better terms, go ask your friendly radiologist. So this is, you can't make the differential just based on CT, but this is a tendency. Amoebic abscesses have a tendency to look more like this, whereas pyogenic abscesses have a tendency to look more like this. Okay, question 16. A 51-year-old man presents to the ED complaining of severe abdominal pain of 6 hours duration, along with 2 episodes of vomiting. He denies any past medical history and says he's normally healthy. He says he's never had any surgery before. There is no record on file for this patient. Physical exam is remarkable for a very ill-appearing male in significant pain and distress. There's exquisite epigastric tenderness, which he says radiates to the back. There's no pain on rebound. There's mild hepatomegaly. There's no abdominal distension. There's mild tremor in his hands. He's hemodynamically stable. Laboratory workup reveals sodium of 145, potassium of 3.7, chloride of 108. Bicarb 23, BUN 27, creatinine 1.2. Blood alcohol is elevated at 0.01. ALT is 105, AST is 190, amylase is 400, lipase is 246. Based on this information, which of the following will most likely not be part of the workup and initial management of this patient? A. Abdominal CT, B. Aggressive IV fluids, C. NPO, D. Admission to the ICU, E. Serial amylase and lipase levels, F. Scheduled lorazepam IV, G. Morphine sulfate IV, H. Seizure precautions, I. Meropenem IV prophylaxis, J. Surgical consultation, and or K. Abdominal and biliary sonography. All right, so again, this is kind of a step 3 geared question, but good to know. You need to know how to manage patients that come in with what is very obviously this disease. And the answer What you're not going to do, most likely, compared to the other ones, is meropenem prophylaxis. So this is a patient with presumed, actually, well, you can actually say it's diagnosed, actually. This is a patient with acute appendicitis. Acute pancreatitis. Acute pancreatitis. And so when you're dealing with a patient with acute pancreatitis, one of the very, very most important things to do initially when you're looking at a physical exam is to look for any kind of ecchymoses. So you're looking at the flank and you're looking at the umbilicus. If there are flank ecchymoses, this is not just your garden variety edematous pancreatitis, as what we probably have in this patient since the physical exam didn't reveal any ecchymoses. But if you do have ecchymoses, what it probably is the much more severe hemorrhagic pancreatitis. And that requires much more intensive observation, and it's much more deadly, and it's just worse overall. So this question basically expects you to know all of the things you're going to put on your management or on your admission orders for a patient with acute edematous pancreatitis. And so let's start out at the beginning. Abdominal CT. Yes, we need to do that. That helps us with our diagnosis. Aggressive IV fluids. This is the most important one of all. You need to hydrate patients with pancreatitis. This can't be overstated. This is the most important out of all of these things, maybe apart from not sending the patient home. But out of all of these things, aggressive IV hydration is the most important. Your patient will die if you don't have IV fluids attached to them. So aggressive IV fluids is very important. NPO, when you have a patient with pancreatitis, they are on bowel arrest. So they're NPO, and that, of course, is going to mandate the IV fluids, as if it wasn't mandated before, and then dextrose in their fluids as well. Admission to the ICU. Yes, you've got to admit these patients to the ICU. These patients are very, very, very sick. You can die from pancreatitis very easily. So these patients need to be admitted, especially if they're hemorrhagic pancreatitis. Serial amylase and lipase levels. These help us track the patient's progression, their resolution of their pancreatitis. So we want to have that. Okay, and then this brings us to another thing with this patient. Note that we have mild tremor in his hands, and we have a blood alcohol level of 0.01, and also that he has pancreatitis. Who gets pancreatitis in the United States? Alcoholics. People who have drank themselves silly. And you can get from that the pancreatitis, which as a result of that, you have to do all this stuff for them, but you also need to tend to the fact that these patients are going to be in alcohol withdrawal. You're going to put the patient in the ICU. He's probably not going to have access to his vodka. So what we need to do is make sure that we are preventing the patient from going into delirium tremens, that we're treating his alcohol withdrawal. And so two of the things that we do, and you can see already that this patient is in alcohol withdrawal based on the mild tremor and the fact that he's got pancreatitis, meaning he's probably an alcoholic, just statistically, and that he has alcohol. Even though it's a low blood alcohol, it's probably low because he's been throwing so much up, hasn't been able to keep anything down. So what we need to do with patients who are in alcohol withdrawal is we need to give them scheduled benzodiazepine. Usually lorazepam is good, Ativan. We also need, though, to take into consideration seizure precautions. So both F and H are related to the fact that this man is almost certainly in alcohol withdrawal. Okay, so this is very, 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 very important. In addition to the fact that you can die from pancreatitis, you can also die from delirium tremens. So we have to make sure that this patient is getting scheduled lorazepam, not a choice. He's got to be on something that's going to calm his nerves down because he's not getting his alcohol as his body is used to. And then seizure precautions, meaning padding around beds, frequent checks from nurses, make sure that they're aware, etc. Morphine sulfate. Patients who have pancreatitis are in pain, and they don't need to be in pain. So we'll give them painkillers. If they're allergic to morphine, you can go with something else. But for all intents and purposes, morphine sulfate is what you can use for this patient. Meropenem. We do not do prophylaxis for patients with acute edematous pancreatitis. That is a fact. It is not best practice. You may have seen it been done, but it is not best practice. So the USMLE will expect you to know that patients with acute edematous pancreatitis do not need to be on antibiotic prophylaxis. And then these other two, surgical consultation, well, that's obvious because pancreatitis is a surgical problem, so you'll want to have surgery informed of this. And then abdominal and biliary sonography. Why do we do that? There is the possibility that this is biliary pancreatitis, meaning you got a stone that went in and obstructed distal to the pancreatic duct. So we'll still look at their biliary tract and see if maybe this is a biliary pancreatitis, because if it is, it will require a little bit different management. All right, so just kind of recapping that. Acute pancreatitis can often be suspected on clinical and laboratory grounds, especially your amylase and lipase being 3 times the upper limit of normal. Abdominal ultrasound will be your best initial diagnostic step. It takes a very skilled sonographer to be able to see the pancreas, much less to be able to see a diseased pancreas, which is full of fluid. But abdominal ultrasound is your best initial step for diagnosing acute pancreatitis. It shows abnormalities of the pancreatic mucosa, although eventually you'll have to get the patient in for CT. You'll also want to visualize the common bile duct and the gallbladder to rule out stones, and you can do that with your abdominal ultrasound where you're looking for abnormalities of the pancreatic mucosa. And then this is just showing about biliary pancreatitis. You should especially consider biliary pancreatitis in a patient who has no history of alcoholism. Typically, acute pancreatitis, we see it in the U.S. in patients with a history of alcoholism. But biliary pancreatitis is a big cause of pancreatitis in the non-alcoholic patient. So we kind of already talked about the treatment for acute pancreatitis, but absolutely necessary. You're in major malpractice if you don't resuscitate them vigorously with fluids. In severe patients, severely ill patients, primarily what I mean by that are patients who come in that are hemodynamically unstable. You should really consider placing a Swan-Ganz catheter for them while they're in the ICU to monitor their hemodynamics more intensively than just monitoring their blood pressure. All right. So some complications that can come out of acute pancreatitis include the pancreatic pseudocyst. This is quite common. Usually presents as a vague sensation of fullness or discomfort several weeks after acute pancreatitis, and all it is a lesion to the pancreatic duct, and you got fluid that came out of there, usually with pancreatic enzymes, and so now you've got this cyst, which is really a pseudocyst because it's not lined by epithelium. You can diagnose this via CT pretty easily. Treatment will be percutaneous drainage. I gave a whole section to pancreatic pseudocyst, so you should go back and look at that. Another complication is acute suppurative pancreatitis. So this tends to happen, it can happen to anyone, but it tends to happen especially in the patient who didn't get a CT while they were in the hospital. If you go back to some of these orders, you should get a CT after 48 to 72 hours, and what you're really checking for is an abscess. So if the patient happened to have a small abscess and you didn't see it, the abscess will of course grow once they're off since they're not on antibiotics, and they'll eventually develop a fever, elevated white count, and of course on CT you'll see the abscess quite easily by that point. Treatment, because you have for the most part, a good rule of thumb is an abscess inside the abdominal cavity really needs to be drained. You'll do percutaneous drainage and then IV broad-spectrum antibiotics. From what I have read in the literature and what I was told by one of the physicians I know who is an infectious disease specialist, imipenem cilastatin is the best drug for acute pancreatitis, but as far as USMLE is concerned, IV broad-spectrum antibiotics is good enough. So this is just shows about acute hemorrhagic pancreatitis, which is another way that acute pancreatitis can present, which is much more severe, and then the biliary pancreatitis, If it is biliary pancreatitis, what we're going to do is the laparoscopic cholecystectomy, because there are stones coming out of there and it's caused a major complication. So we want to take that gallbladder out. Okay, so I talk about this in much greater detail in the pancreatitis section, acute pancreatitis section. All right, question 17 gives us a 29-year-old woman presenting with the ED complaining of right upper quadrant abdominal pain. She is generally in good health and denies drug or alcohol use. She has no surgical history. She denies the use of birth control. Her medications include escitalopram for moderate anxiety, droperidol ethinyl estradiol for acne, and loratadine over-the-counter for seasonal allergies, which I would really like right now. Physical exam reveals right upper quadrant tenderness and what may be a small palpable mass. There is no guarding or rebound. Rectal exam is negative for masses or stool guaiac. Abdominal ultrasound reveals an ovular-shaped 3 cm hypoechoic lesion in the parenchyma of the right lobe of the liver. Otherwise, the ultrasound is unremarkable, meaning no stones. Which of the following is the most likely diagnosis in this patient? A. Hamartoma, B. Focal nodular hyperplasia, C. Hepatocellular carcinoma, D. Hepatocellular adenoma, or E. Cavernous hemangioma. Okay, so the answer to this one is D. Hepatocellular adenoma. Now, there's one thing that I put in this question for a purpose that we'll discuss in a couple slides from now, and that is that she denies the use of birth control, but she's on droperidol ethinyl estradiol, which most of us know is birth control. Now, there are reasons that women are on birth control for reasons other than not wanting to get pregnant, and sometimes that doesn't get communicated to them, and that is not their fault by any means. That is our fault. And so I wanted to illustrate the fact that if you ask a woman that if she's on birth control and she is on a birth control medication, she's not using it as birth control, she may not tell you, she may say, no, I'm not on birth control. I'm on droperidol ethinyl estradiol for my acne. I'm on Yaz for my acne. That's the same thing, though. All right, so back to the medical side of this. So you have a woman that you know is on birth control based on her medication list, and she's got right upper quadrant fullness, and she's got this mass, this lesion in the parenchyma of her liver. So what is it? Well, women who are roughly 20s, 30s, who have a mass, who are on birth control, and who have these ovular lesions in their liver, the most common diagnosis is hepatocellular adenoma. And so hepatocellular adenomas are strongly associated with the use of oral contraceptive pills, although I would also probably add to that it's probably also associated with contraceptive devices as well. It's also associated with anabolic steroids, pregnancy, and certain fertility drugs. Women tend to be affected more than men, and that's a strong correlation, 9-to-1. And there is malignant potential from hepatocellular adenoma. It can transition into hepatocellular carcinoma. So the symptoms are far and away, usually these patients are asymptomatic, and it's discovered incidentally or it's discovered when it ruptures. But sometimes the patient can have right upper quadrant pain or what's described as fullness. And when you do the exam, you feel a palpable abdominal mass, which is going to lead you to do an ultrasound. So for diagnosis, you gather your suspicion based on your physical exam and sonography, but in order to really diagnose this, really make your official diagnosis with your hospital stamp of approval, you got to get a MRI with gadolinium enhancement. Is that always done? No. But that is the most accurate diagnostic test. Other things you can do theoretically you can do it, but you really shouldn't, is a biopsy. Why do we not want to do a biopsy? Because these are masses that can rupture, and when they rupture, they bleed. And what is the last thing you want to do on a mass that can bleed? Poke a hole in it, and that's what you're doing with a biopsy. So you don't want to do a biopsy. So besides the biopsy, the most accurate diagnostic test is the MRI with gadolinium enhancement. Workup can also include an alpha-fetoprotein level, and alpha-fetoprotein is to a certain degree associated with the hepatocellular adenoma, although when it's at higher levels, we're concerned about hepatocellular carcinoma. So for the treatment for hepatocellular adenomas, if it's asymptomatic, you leave it alone, document it, but leave it alone, and you just monitor it by annual sonography, patient education, and annual alpha-fetoprotein levels. The patient should also discontinue any oral contraceptives and any anabolic steroids, as well as avoid pregnancy. Now, if she wants to get pregnant, we can work around that. We can remove it. But in the meantime, she should avoid pregnancy until she decides she wants to get pregnant, in which case then we can remove the adenoma. Other reasons to remove the adenoma is if, like in this patient, they're symptomatic, or if they are large. And by large, usually it's like more than 4 to 5 centimeters. Like I said, you should also monitor with annual sonography and alpha-fetoprotein. If it is a ruptured adenoma, which it often presents as, in that case, you will hemodynamically stabilize the patient and then send them off for emergent surgery. All right, and this I wanted to illustrate. Oral contraceptive pills are taken for reasons other than birth control. So if you just ask a woman, are you on birth control? That's not a good way to ask it. Better way to ask it is, are you taking any medications that are also used for birth control? Or are you on any medications that affect your cycle? Some women don't, they're on these pills, but they don't consider it birth control because they're taking it for, not for birth control, but for polycystic ovarian syndrome, or for acne, or for endometriosis, or because they have painful menstrual cycles. So they don't consider it birth control. And so if you ask them just flat out, are you on birth control? They may say no. So a better way to ask, a more professional way to ask is, are you on any medications that affect your menstrual cycle? And they'll say yes, because these medications do affect their menstrual cycle. Most women will tell you, if you ask them, are you on birth control, they'll know that their medications are also used for birth control, but a better way to ask it, because some of them might not consider it to be birth control because that's not why they're taking it. A better way to ask is, are you taking any medications that affect your cycle, or just go straight to their medication list if possible, and if you see that they're on any of these drugs that are also used for birth control, well, then they're on birth control. So some examples of reasons that a woman may take oral contraceptives for reasons other than not wanting to get pregnant, as in this case, drospiridol, ethinyl estradiol, which is Yaz or Yasmin. This is a drug that's really, really fantastic for getting rid of acne. So if a woman doesn't mind being on birth control, or if she even if she wants to be on birth control, you can knock out 2 birds with 1 stone. You can get rid of her acne, which she doesn't want, and you can have her on birth control, which she may want. So this is a good drug for that purpose. Medroxyprogesterone, which is marketed as Provera, and ethinyl estradiol are both used for polycystic ovarian syndrome. Usually these women, though, are treated by an OBGYN, so they are plenty educated on what they have. OBGYNs are very, very good doctors as far as the patient education side. So I wouldn't worry about that too much. Norgestimate ethinyl estradiol, again, probably in the care of an OBGYN who's made them well aware that this is a birth control drug. Endometriosis. And then there are many, many, many different oral contraceptive pills or contraceptive devices, get rid of the O there, that are used for dysmenorrhea. Obviously, if you have a woman not have her cycles, then that's going to make dysmenorrhea much better because she's not menstruating. So these are the benign lesions of the liver. I talked about them in greater detail in a specific section for that. But this was a patient with a hepatocellular adenoma. The star here means it has the potential to degrade into a malignant lesion. All right, question 18. So we have a 35-year-old woman presenting to the ED via EMS. She was found confused and acting strangely in her work's break room by her coworker. The paramedic says that she had fainted by the time they got there, and also notes that her medical alert bracelet says that she's hypothyroid and she takes thyroxine. Fingerstick glucose test showed a reading of 35 milligrams per deciliter. 1 amp of 50% dextrose was administered, and her blood glucose came back to 75 milligrams per deciliter. It has now, however, dropped back down to 40 milligrams per deciliter. Another amp of 50% dextrose was administered. IV fluids have been started, and levels for plasma insulin and C-peptide levels have been ordered. Plasma insulin is elevated, C-peptide level is normal. You review her medical chart, she is not prescribed insulin. Which of the following is the most likely diagnosis in this patient? A. Munchausen syndrome, B. Iatrogenic hypoglycemia, C. Insulinoma, D. Nocidioblastosis, or E. Thyroxine toxicity. Okay, and the answer to this question is A. Munchausen syndrome. So, as you probably gathered if you watched enough of my lectures, I love psychiatry, and so I would work it into a surgery review. But this is important to know. What I wanted to really illustrate here was the importance of getting C-peptide levels in addition to plasma insulin level. So what we have here is a woman who has hypoglycemia. Not only is it hypoglycemia, but it's a refractory hypoglycemia. You've already given her dextrose. You would expect her to no longer have hypoglycemia now, but it came back. And so we are concerned about hyperinsulinemia. For whatever reason, there are many reasons that can happen, but we're concerned about hyperinsulinemia. In addition to getting your plasma insulin level, though, that's not enough. You need to also get your C-peptide level. What is C-peptide? C-peptide is a little tail that's on insulin when it's first made, so like baby insulin. And before the insulin is put out into the bloodstream by the pancreas, that C-peptide is taken off. It's cut off by an enzyme. And so anytime you make your own insulin, you should also be making your own C-peptide too. And so if you're making your own insulin, your plasma insulin level is congruent with your C-peptide level. If you're not making any insulin, you're not making any C-peptide. If you're making a normal amount of insulin, you're making a normal amount of C-peptide. If you're making too much insulin, you're making too much C-peptide. They're congruent. They're parallel. Now, on the other hand, if you're getting insulin exogenously, like for instance a diabetic, it's not going to have the C-peptide on there. There's no point in putting the C-peptide on there because it's not necessary for it to work. So if you're getting insulin from, if you're diabetic and you're injecting yourself with insulin, you'll have an insulin level, but a C-peptide level that's lower than what you would expect in a patient who's making their own insulin. Okay, so that having been said, here you've got a woman who's hypoglycemic. She's got a high insulin level, but not the C-peptide level to match. So we know right off the bat that she's not making too much of her own insulin. She's getting insulin somewhere else. So we can eliminate insulinoma, because in insulinoma, you're making your own insulin. We can also eliminate nocidioblastosis, because if you know what nocidioblastosis is, you know that this is a disease of babies, not of adults. So we can eliminate that. Thyroxine toxicity can cause, in rare cases, can cause hyperglycemia, or hypoglycemia rather, but it is not going to cause an elevated insulin level. So get rid of that too. So now we're down to Munchausen syndrome and iatrogenic hypoglycemia. With the iatrogenic hypoglycemia, what that is I took too much insulin, but it was a mistake because I don't know how much insulin I'm supposed to take, or I misread it, or I just put too much into the syringe. Either way, iatrogenic hypoglycemia means it was a mistake. Munchausen syndrome, on the other hand, means I'm going to inject myself with insulin so I can get some attention. And I mean, I make that sound really bad, and these patients truly are psychiatrically ill, and so it's not just that. But regardless of what it is, the fact is that this woman has elevated insulin level, no C-peptide level to match it, so you know she's getting insulin from somewhere else, and she's not prescribed insulin. So she knows that she's not supposed to be taking insulin. And so this is not a mistake. This is Munchausen syndrome. She did this to get attention for some reason. So you need to know the difference between Munchausen syndrome and iatrogenic hypoglycemia. USMLE may throw that at you. They'll expect you to know that iatrogenic hypoglycemia is a mistake, maybe a new type 1 diabetic patient who's trying to get down their the amount of insulin that they're supposed to take and when they take it, or perhaps a malfunction of their insulin pump that they have attached to them, or perhaps an older patient who just didn't read the syringe properly. So if you've seen these syringes, they're really small, so if your vision is going, you may misread it. But this is Munchausen syndrome. Okay, but I wanted to work in some psychiatry at the same time as working in some surgery too. So this question was designed to be both educational and entertaining. Question 19. 67-year-old woman presented 2 months ago complaining of a left breast mass, or breast lump. Physical exam was significant for a firm and mobile mass in the upper outer quadrant of the left breast. Mammography was performed and identified a 2.4 by 2.1 by 2.6 centimeter lesion. She then underwent lumpectomy with biopsy and sentinel node biopsy. The biopsy showed infiltrating ductal carcinoma with clear margins on all sides, and the node was positive for cancer cells. The tumor cells are strongly positive for estrogen and progesterone receptors and is HER2/neu negative. In addition to removing the involved lymph nodes, which of the following would be the best treatment plan for this patient? A. Bilateral modified radical mastectomy. B. Left modified radical mastectomy. C. Chemotherapy and tamoxifen. D. Chemotherapy and anastrozole. Or E. Chemotherapy and estrogen progesterone hormonal therapy. And by that I mean estrogen progesterone agonists, as if you were to just give her estrogen and progesterone. Okay, answer here is D, chemotherapy and anastrozole. And you could probably nitpick that and say you can just give her anastrozole, because in older patients, anastrozole itself is just as good as giving her chemotherapy and anastrozole. Okay, so that being said, let's look at this patient. We've got a woman who has had a mass. She's had it worked up and everything, and we know what it is. It's infiltrating ductal carcinoma. It's been removed. You've got clear margins. The node was positive for cancer cells. So in addition to removing the involved lymph nodes, what else are we going to do? We got a patient that has a systemic cancer, a cancer that has metastasized either to the nodes or to the to other parts of the body. This is a ductal carcinoma. Now, if you were to have a lobular carcinoma, you should know, either if you're talking about lobular carcinoma in situ or infiltrating lobular carcinoma, that lobular carcinomas have a strong tendency towards bilaterality. And so anytime you've got a person with lobular carcinoma, you're going to want to make sure that you take some kind of precautions towards both breasts, not just one. So this is a ductal carcinoma, so you don't need to do anything bilateral. A modified radical mastectomy may be unnecessary in this patient because what you've already done is a lumpectomy and you got clear margins. And so you took out the tumor. Now, in addition, of course, you are going to remove the lymph nodes. That's part of the procedure. But as far as we're concerned here, we don't have any other metastasis, because part of the workup for breast cancer is looking for any other metastasis. And if you don't see any, you don't have any. So we're not going to go any further than lumpectomy initially. What we do need to do, however, because we have a positive node, or if we were to have metastases, we need to do some kind of chemotherapy or hormonal therapy. So what do? You can eliminate E, because you're never going to want to give any patient with breast cancer estrogen and progesterone. That's going to make the breast cancer worse. So it's really between C and D. If this were a premenopausal patient, you would give her tamoxifen and the chemotherapy. But in a postmenopausal patient, you can give her, and you should give her, anastrozole. And actually, and I could have probably worded this question better, anastrozole is perfectly fine to be given as monotherapy. You don't need to add on the chemotherapy in addition. I mean, you can theoretically, but anastrozole by itself is perfectly fine for a postmenopausal patient that you want to give therapy to. Okay, so just some pictures of what breast cancer can look like on physical examination. So here's dimpling of the breasts. Here is also dimpling here, and nipple retraction. Nipple retraction, and probably dimpling right here. Nipple retraction here, and dimpling here. Here you have overlying erythema. This is a scary sign because this suggests inflammatory carcinoma. And this is even more scary. This is the peau d'orange, or orange peeling. And it's called that because it looks like an orange peel. And so you also have nipple retraction here, but you've got the orange peeling. And this is because of the what's going on inside the breast. It's causing destruction of the infrastructure of the breast. This is just a little cartoon here that's kind of showing what lobular and ductal carcinoma in situ are versus the infiltrative versions of those same cancers. So what do we do for treatment? Ductal or lobular breast cancer. Please note, this is not including inflammatory breast cancer. This is just the ductal or lobular breast cancer. Initially, we're going to do the biopsy. We have to do all the things that help us work up whether or not this was that this is metastasized. So that's going to include chest X-ray, looking at the lungs, CT of the liver, and liver function tests, looking for any metastasis to the liver, and then bone scan, looking for, of course, metastasis to the bone. If it's localized, and by localized, we're pretty much, what we mean is that it's not moved anywhere outside the breast, including the lymph nodes. You do a modified radical mastectomy or a lumpectomy with sentinel node biopsy and radiation. So with this patient, we did the lumpectomy and the sentinel node biopsy and radiation. So we don't need to do the modified radical mastectomy. These two therapies are equivalent in survival. The only difference is that with a modified radical mastectomy, you completely obliterate your chance of the cancer coming back in that breast because you've taken it off. But it doesn't improve survival to do the modified radical mastectomy. If you have a systemic breast cancer, meaning that it has gone to the lymph nodes, or that it has gone to the bone or the liver or the lungs, etc., then you're going to, in addition to taking the tumor out, you're going to do chemotherapy and radiation and hormonal therapy if the tumor is estrogen and progesterone positive. I know I didn't include radiation in the answer choices, but none of them included radiation, so they were all equivalent. Okay, so the hormonal therapy is done if the estrogen and progesterone receptor is positive. It is in most cases, and so we give drugs that block estrogen and progesterone so that we're not feeding the tumor, basically, or any remaining tumor cells. Adjunctive therapy can be done, and by this I mostly mean trastuzumab, which is done for the HER2-neu positive tumors. It used to be that HER2-neu positive tumor was a really, really bad sign, because these things grew relentlessly. Suddenly, there came trastuzumab, which is called Herceptin. And this is a drug that blocks these receptors, and now, if you have a HER2-neu positive tumor, you actually have a better prognosis. It used to be you had a worse prognosis, now you have a better prognosis. So we give these patients Herceptin. So the treatment strategies for breast cancer, chemotherapy is generally indicated for patients with positive lymph node status, and it's always indicated in patients with metastasis. Hormonal therapy is indicated for patients with tumors that are positive for estrogen and progesterone receptors, as we had in this case. In postmenopausal patients, you can just do the hormonal therapy. You can just give them the anastrozole. And like I said, the HER2-neu oncogene positive patients should be put on trastuzumab, and then you should always intensively follow up any patient. So in this patient, you'd probably also do radiation in addition, but didn't put that in the answer choices. All right, question 20. A 60-year-old man presents to your clinic complaining of abdominal pain and fatigue for the past 3 weeks. He's an immigrant from Japan and has lived in the U.S. for 23 years. He's has no significant medical issues. He's smoked half a pack a day for 40 years. His medications include atorvastatin and a baby aspirin. He has a history of peptic ulcer disease, which was successfully treated 5 years ago with Helicobacter pylori eradication, triple therapy, and there have been no symptoms ever since then. He has no surgical history. Physical exam reveals pallor, mild epigastric tenderness, no rebound or guarding. Rectal exam is negative for masses but positive for stool guaiac. There is palpable nodule above the left clavicle. Routine labs are significant for a hemoglobin of 8.8 with a MCV of 78. Which of the following diagnostic tests would most likely yield the most significant results in this patient? A. Upper GI endoscopy with biopsy. B. Lower GI endoscopy with biopsy. C. Barium swallow, D. CA levels, or E. Bone marrow biopsy. And the answer to this question is A. Upper GI endoscopy with biopsy. Our working presumptive diagnosis here, based on this patient's risk factors, his history, his symptoms, is a gastric adenocarcinoma. And so in order to diagnose that, you're going to want to go in with an upper GI endoscopy. That's going to make the official diagnosis because that's how you get your biopsy. So let's look at gastric adenocarcinoma. This patient had all these risk factors. So first off, he was male. Male sex is a risk factor. He was older than age 50. Older age is a risk factor. He's not white. People who are not white have a higher tendency to get gastric adenocarcinoma. So a better way to put that is white people have a lower tendency towards adenocarcinoma than non-white people. That's just how it is. East Asian nationality. Why do I say nationality and not just East Asian? Because East Asian people who are, like, let's say they're the child of Japanese immigrants and they were born in the United States, they don't have the same risk as, let's say, people who are from Japan or from China. So if you grew up in the United States, then the East Asian factor does not play a role. So that's interesting, but we don't really know why that is. And it probably, though, has something to do with this fact that a diet high in smoked and salted fish and certain other foods increase your risk of gastric adenocarcinoma. So that may have to do with the cultural factors, the diet, etc. Not that our American diet is something to brag about. H. pylori infection is another risk factor, and then tobacco use as we had in this patient. So we had the male sex in this patient, we had the older age in this patient, the non-white, we had the East Asian nationality, we had the H. pylori infection, or the past H. pylori infection, and the tobacco use in this patient. So all of those risk factors were present. What do we do for treatment? Well, I mean, this is skipping how you diagnose the patient, which is via biopsy. But for treatment, once you diagnose them, it's going to be surgery. This is the only curable possibility. It's going to be a subtotal or total gastrectomy. And this is for patients with no metastasis. If the patient has metastasis, unfortunately, nothing you can do other than palliate the patient and give them chemotherapy. That's part of the palliation. So the palliative surgery is performed for patients with bleeding or obstruction. If you have gastric outlet syndrome, you can't get the food through the stomach and into the small intestine, you can do a palliative surgery for that. But the only way to cure this patient surgically is via a subtotal or total gastrectomy. Chemoradiation can be done. It can be done either palliatively or therapeutically, and that's via 5-fluorouracil and leucovorin. 5-fluorouracil. This is I want you to know about this. And this is not for clinical practice. This is for a multiple choice test. If you have a multiple choice test, and the question is, what chemotherapy do you do? If it's a GI cancer, 5-fluorouracil is probably the right answer because 5-fluorouracil is used so much in the GI cancers. It's used in colon cancer, it's used in stomach cancer, it's used in esophageal cancer. It's used all over in the GI tract. So that's just a little pearl. The survival, unfortunately, for gastric adenocarcinoma is poor, usually because by the time you see it, it's already spread and is too invasive for treatment. The survival is primarily going to depend on the depth of invasion. One of the very first patients I saw when I was on my GI rotation as a fourth-year medical student was a patient with gastric adenocarcinoma. Very, very nice patient. And it broke my heart because, I mean, I was just a medical student, and my attending told me just kind of flippantly, yeah, this patient's going to be dead in 6 months. I was like, no, that's terrible. But yeah, this is a very sad, sad cancer. And with that, I will see you in the next section.